All right, hi everybody. I think we're going to go ahead and get started. Thank you so much for joining us at this last session, for hanging on in here. I know many of you are probably getting ready to catch flights or heading on out. This has certainly been just a phenomenal ADRC meeting. I'm so pleased that it was focused on DEI issues, and am pleased to get to lead one of these cross-core breakout sessions. So this is the session for research translation for all persons. If you're looking for the brain bank session, it's in a separate room. So just so you know, that's what we'll be talking about today. This will primarily be a discussion. So each speaker, I will introduce them. They'll be coming up and having about 10 minutes to talk about their vantage points, their personal experiences, and their views on this particular topic. But I will go ahead and set the stage for us very briefly. So ultimately, as we all know, the burden of AD is not distributed equally. We've been hearing about that throughout these last two days, and of course, many of us have been working in this area for much longer. And the ADRC really has an opportunity, as well as what I would say a responsibility, to take in what has been discussed over these last 2 days, all of the important strategies, all of the important approaches, and really think from a broad perspective how we can ensure that the important momentum is not lost and that systems are changed in order to facilitate excellence across the center's network in the disparities space. That type of excellence should be the norm for us as a research network and not be the exception. So as you know, for those of you who were in the last session, there are some major new federal policy changes coming forward that are making it now legal to think about changing the way that resources are allocated and funded. And I think we can think about that from the research perspective as well. So the purpose of this session is really to think broadly, to think at a high level, to think about policies, different operations, and coming together as a network to engage further discussion with outside groups, including industry. So without further ado, I'm going to kick us off then. These are my funding disclosures from the National Institutes on Aging and National Institutes on Minority Health and Health Disparities fund my work, and I've received travel funding from the Alzheimer's Association. So as we know, brain health is not distributed equally, and we need solutions, and so much of that is about participants having access to interventions that are tailored to their needs. And when I say interventions, I'm not just talking about pharma interventions or non-pharma interventions, but the entire package of activities that goes on to not only bring someone into a study, but to retain them in that study and to ensure that the care and intervention that they have access to really is designed for them. Many other groups are pushing forward in this same alignment as we speak. I quickly took this screenshot. Sorry, I know it's a little grainy, but I hope all of you have seen this report. This was the National Academy's report that came out on improving representation in clinical trials research. It was just published about 12 weeks ago. It was informed by many leaders across the ADC system. And it has a lot of great ideas, especially at this very broad policy level. Some of their conclusions will not be a surprise to you after listening to the conversations today. They say, National Academy says, improving representation in clinical research is urgent. It requires investment. We have to rethink how we pay for research and what we value, and help our IRBs to come along with that. It involves improving representation, requiring transparency and accountability. We need metrics that not only we can measure and count, but that we can respond to. Improving representation in clinical research is the responsibility of everyone. It's not just the responsibility of the ORCORs, it's not just the responsibility of the diversity researchers or populations. This is all of our responsibility. And so this is something that as a network we all need to carry forward. But getting there is going to require a paradigm shift. In this report by the National Academies, they did a full assessment of clinical trials that have been published in the last few years. And the outcomes are horrible, absolutely horrible in terms of representation. So as we've heard, we have lots and lots of resources, lots of experts that can tell us what needs to be done. But from a system level, they're not happening routinely. And in my world of health policy work and thinking about things from a standpoint of economics in particular, it speaks to the need for a fundamental change in thinking about how we incentivize this type of behavior. The FDA is also adopting these positions. They are Robert Califf, many of you probably know. He was the prior FDA commissioner, and he was just reappointed by the Biden administration. They just published a statement in Science. This is just from a few weeks ago. You can read it here. The U.S. is experiencing a decline in life expectancy, and as part of a wider effort to reverse this decline, relationships between FDA and biomedical ecosystems should be reimagined to facilitate more effective translation of science into successful health interventions. The biomedical community, that's us, should review our priorities so that we can deliver more new therapies, particularly for those suffering most, racial and ethnic minorities, people with less education and wealth, and those living in rural areas. This is from the ADC statement. I don't know how many of you have looked at the website. I'm guessing you copied and cut and paste and put this in your grant at some point when you're applying for an ADC. But the Alzheimer's Disease Research Centers, this is our job. It's to find treatments and prevention strategies for AD and other related dementias and translate those findings into improved diagnoses and care. The blue 3 words I added, I would argue that it should say for all persons. And this is something that I think we need to think about intentionally as we develop interventions and as we develop research programs. You've all seen this, the NIH Health Disparities Priority Populations. We've talked about quite a bit of these populations during these last 2 days, but to also highlight the importance of intersectionality between these different groups. And individuals are all different and carry with them different patterns of these social constructs. And so when we think about interventions and we think about designing interventions for populations, of course, we often think about treatments and non-pharmacologic interventions, clinical and social interventions. But as that beautiful ORCOR, I hope you all heard the ORCOR talks that went forward just earlier today, there are all sorts of barriers to individuals receiving these interventions. Even if we came up with the best possible treatment for Alzheimer's disease, still there would be barriers to receiving those treatments. And I've listed a few through the pictures on this slide. There's many, many more. But again, thinking systematically, not just about that treatment, but about the other aspects of those trial accessibility and how we can make that happen from a policy standpoint. Going back to the NASEM study, they say that in order to remove those barriers, we need a substantial investment of time, money, and effort. And we all know from the funding that we received and the grants that we've written, time in particular is a challenge, right? We've talked about the foundational infrastructure that needs to be present over time in a long-standing way with communities to build those relationships, to maximize those asset-based opportunities. And we have to think about how that could be funded and whose responsibility that is. Should clinical trials have a certain amount of extra expected investment into the communities? Can this be leveraged from an economic standpoint? Should we be paying for not only participant payments, but thinking about all of the other payments that should be going into really doing responsible research in these communities and funding that infrastructure in a way that it hasn't always been funded, and not just piecemeal, but in an ongoing way? So the National Academies say that investments are needed in the systems and technologies to reduce burden of participation by underrepresented and excluded populations, such as, so not just these, but these are examples, by adequately compensating participants, by making participation more physically accessible, and providing research materials that are culturally informed and multilingual. This ultimately can hopefully start to remove some of those barriers. It's just a first step, but to get there, we can't keep doing the same type of models, the same type of financing, the same type of policies that we've done in the past, because they're not working. They're not working outside of the groups that are, of course, showing excellence in this area. But when I say they're not working, I'm talking about all of those clinical trials that have been published without adequate representation. In order for pharma or some of the other big groups to change their behavior, there's going to have to be some sort of standard policy put in place. And of course, I really think money is one of those big ones. Not just money for participants, mind you, but money for the infrastructure that's required to meet participants for where they need to be met in order to participate. And thinking about the fundamental expectations of the financing of these types of trials. So of course, this brings us to policy, and as all you know, I am very involved in policy. I think policy, I've seen changes happen with policy in a way that haven't happened in other places. So when Centers for Medicare and Medicaid Services, for instance, changes the way it pays for care, you watch how quickly those hospitals sit up and change their behavior. It's fascinating. And the same can sometimes happen with other types of investment and potentials. So we talked about, if you were in the last session, we talked about the Area Deprivation Index. For those of you that weren't there, I'll give you a brief overview. This is an exposomal metric that our team has produced that includes 17 different measures of the social determinants of health across small population-sensitive areas. It's linked to a whole host of brain and other health outcomes, and it's fully available through the Neighborhood Atlas, completely democratized. This is a tool that's getting over 1,000 downloads, full data downloads every 2 weeks, but tens of thousands of hits each month. The ADI itself is going to be included in the DNA of so many of the different AD infrastructures. I've been working with leaders at ACTC and ADNI to include these metrics. It'll be in HOBS and in the UDS going forward. But one of the exciting things is that the Centers for Medicare and Medicaid Services are now using this very same metric to change the way it pays for care. Because CMS has the same issues in some ways that we do in clinical trials. How do you help individuals to access needed care involves removing many of the same barriers that we encounter in clinical research. Obviously, there's some different ones, but the social determinants of health-focused barriers are quite similar. And so CMMI is charged with the Affordable Care Act. It was produced, this branch of CMS was launched with the Affordable Care Act during the Obama administration, specifically to try to rein in costs of care, but also to improve health equity. And what CMS is saying is that for patients that are living in these red areas in the Neighborhood Atlas who have very high ADIs, those health systems that are caring for those patients will receive more money in an algorithmic prospective way that can be budgeted for in advance. That money is cost neutral, and it's coming from sites that are primarily low ADI neighborhoods, so areas that are very blue on the map. And the idea of these additional payments to those high ADI areas is exactly this. It's exactly to remove these barriers to treatment, to provide the needed supports that are necessary in order to get those FDA-approved treatments. But again, this fiscal approach can be thought about as a potential way to change clinical trials as well. And so just to summarize, this is what it says. Blue areas, low money, red areas, high money. That's as simple as it gets. And, it's fascinating when we think about budgeting, prospective budgeting in a clinical research trial, right? Or talking to pharma as you're going to start enrolling participants. And of course, many times they're paying per participant. What if there was an opportunity to set the rules up front where those individuals that were coming from certain areas or had certain characteristics, ultimately that the cost per participant was just expected to be higher? And those costs, some of it would go into participant payments, but a lot of it might just go into the infrastructure that's required to maintain safe, responsible, and respectful community engagement. So we're going to launch into questions for discussion after each of the speakers come forward. We're going to have lots of time for discussion in this session, but I want you all to start thinking about some of these questions, and I think some of our other speakers are going to weigh in on these and other points. But as a network, again, thinking very, very broadly to not lose the momentum that's been gained across these 2 days, should we launch efforts towards creating an equity-focused policy standard for interventional trials in alignment with the National Academy's report? Should financing of interventional trials be grounded in the principles of equity in alignment with the new CMS payment policy, which is truly groundbreaking, and this idea of adjustment allows for prospective budgeting into and negotiations and business agreements in a way that hasn't been offered before, and it is legal. And then finally, what is the role of the ADRC network in setting equity-aligned standards for industry and other interventional studies? If all of our ADRCs were to come together and tell pharma that this is what we expect in order to engage with us to do clinical trials, I think that would set a pretty strong precedent that others would probably follow. So these are questions for us to discuss. It's not to say that we have to go in this direction, but the point is to start the conversation. And I am going to stop there and move on to our next speaker. So I am absolutely honored to be able to pass the stage over to Dr. Maria Carrillo. As Chief Science Officer of the Alzheimer's Association, Dr. Carrillo set the stage sets the strategic vision for the Alzheimer's Association Global Research Program. Under her leadership, the association is the world's largest nonprofit funder of Alzheimer's research, currently investing over $250 million, and is an internationally recognized pioneer in convening the dementia science community. Many of you know Dr. Carrillo. She is a wonderful, wonderful leader in our field, and she is here to share with you some of her personal experiences in accessing care for her family. So thank you so much for coming, and thank you for being willing to share. Please welcome Dr. Carrillo.
Great job. Thank you. What an honor to be with you and be asked to talk about this. So I'm not going to talk I'm not going to talk at all about the Alzheimer's Association. Don't tell on me. I know this is being recorded, but I am going to just give you a little snapshot of something that is very personal to me. So this is a safe zone, right? Right. So just in disclosures, I am a full-time employee of the Alzheimer's Association, and I do have a family member at the University of Southern California in the graduate program of neuroscience. So I have to disclose that. So the reason I'm up here today is because I am first-generation Mexican-American, born and raised in Chicago, as is my husband, first-generation Mexican-American. First-generation to me, because I think some people have different sort of definitions of that, is that I was born in Chicago, but my parents were immigrants from Mexico. And for many years, when I was younger, we lived as an illegal immigrant family. So I learned English at Head Start. How many of you have heard of Head Start back in the day? It was a very wonderful program. I learned English by going to Head Start, and as did my brother. And my husband learned English later because he went back to Mexico when he was 2, came back when he was 11, and had to just jump in and was immersed into English. So I always tease him because he has a slight accent because he learned English later than me. So, but the reason I'm telling you that is because my first experience with Alzheimer's was certainly with my great-grandmother, but that was in Mexico. And that should give you maybe a little insight into how we deal with things in a sort of very traditional Mexican family. Great-grandmother had Alzheimer's. How did we know that? We don't really. I'm guessing that today because in her 80s, she was getting lost every day. But it's not a big deal because she was happy, the family's happy, everybody's protecting her. It's like, oh man, she got lost again, and send a kid to go find her, you know? I mean, you just go find her in the town you live in. Very different in Chicago, where my experience then that was more personal was with my husband's mother. She was the third of 4 siblings to develop Alzheimer's. And in Chicago, when you get lost, it's not safe. She would take the bus because she never learned how to drive. And she would end up in very different neighborhoods from hers where she did not recognize where she was, and she was brought home by police. One time she was also brought home by a Good Samaritan. We were very lucky. But that was not enough for our family to acknowledge that she needed help. It's not enough because there's stigma. You protect them. You hide it, and it could be considered a bad day. And she was very taken care of. Our grandparents are coddled They are protected. She didn't have to do a checkbook. She didn't drive. I mean, she was taken care of. So the way she got her diagnosis was by a fall, which tends to happen for people with Alzheimer's, and then went to the emergency room and came out with a cast and a diagnosis of moderate Alzheimer's. That's important because today we understand that the earlier we can diagnose, the better the patient journey, the better the care, coordination, the safer we can make a home, the safer we can keep our loved ones at home or in another setting, and potentially the better for future treatments. We did not have that opportunity because of the way our family dealt with it, and because clinicians, when this would be raised with them, first said that she had depression and put her on an antidepressant, her PCP, and never wanted to take any action further than that. So we were just a victim, I think, of what you see published, that people of underrepresented backgrounds go into a diagnosis much later, and that is something that we all need to work together to change, and that's why we're having these fantastic discussions. So how did we deal with her care? Very interestingly, between being protected and having stigma, we don't want to admit that she has Alzheimer's, even once you have a diagnosis. So, and we don't put our loved ones into any type of formal home. We keep them at home. So we organized 5 other non-documented individuals who lovingly took care of them 8 hours a day, 3 shifts for 24 hours, and we paid them to come in and out every day so that they could also have their food prepared for them. I mean, these women could cook. Our loved ones got chubby. Chubby. So it was great. Listen to their music all day, have their television, their telenovelas all day. It was a beautiful setting, and we are very lucky that we could afford to do that. And even when we had to do hospice for 2 weeks, we still, the only reason we took our loved one out of the home and into hospice was because we loved our carers so much that the family did not want the carers to have her pass on any one of their watch, because they would have been devastated that she passed on their watch, even though we all know she was passing. So this is how immersed our families are around everything, but everything is a secret. About 8 years ago, NBC asked the Alzheimer's Association, because I do bring this story up occasionally, but never brought it up publicly until she passed, because I was not allowed to. But I did mention some examples of my family and what we have been dealing with, and they wanted to do a story on our family, because here I am working with the Alzheimer's Association and have a loved one living with Alzheimer's, and they wanted to interview the family, and they wanted to follow. They were like, "Are you crazy? Absolutely not. This is a secret. We do not talk about this." And so until she passed, I have not been able to have conversations with anyone about this, other than close friends. So this is just the way we work. And as I'm thinking about how you all work and the fantastic changes that are happening at the Alzheimer's centers, the fantastic discussions we're all having because of so many unfortunate events that have forced us, kind of the scales have fallen off our eyes, and what have we been doing, right? It's great to hear that. But as I reflect like where we lived here in Chicago, Pilsen, if you are aware of where that is, it's primarily Mexican neighborhood, not too far from here, but it is undergoing some significant displacement, because now I go to Mass on Sundays in my parish in Spanish, and I see hipsters like walking around. Like there's some serious displacement happening. But I go to my parish and I see people who are a mix, but many of them are undocumented. And I think about where they are, where they live. They don't trust COVID vaccines. They fear that Mexican Americans, that the government wants to take away their opportunity to procreate. So it's dangerous to go to the doctor. They feel that COVID vaccine was going to inject a chip or give them some other illness. I mean, there are some really different ideas out there. So we have to meet people where they are, right? And as I'm thinking about my community and my colleagues from Rush, I was at Rush for 7 years, and I think about how Rush might have an impact. How can Northwestern have an impact? We're a little bit different as a community than the Black American community, right? I think the churches are a fantastic way to go, but Catholic churches don't allow you to do this. You cannot go in, and that's most of our community our Catholic or go to Catholic churches, especially our immigrant community. So what can we do? And I thought about where we went as little kids. We went to the community neighborhood clinic. It's a doctor that spoke Spanish. We trusted that person. We paid in cash, so we're not really in systems. And that's where we trust, right? So the Reverend earlier today is right. You have to go into the community. You have to spend time with the community. They have to learn how to trust you. And it's about where you go in that community and say, and there's a clinic for those of you in Chicago right there on Ashland, Blue Island, right? It's one of them. It's one of the largest serving in Pilsen. You go there and you say, what can we do for you? What do you need? How can we help you provide information even about memory, but not even that? Blood pressure, diabetes, all the things that we all have as Mexican Americans. And so these are very different conversations, and they're relationships that take a long time to build. So if we're going to be successful, we have to be doing that, and there's no one size fits all for one community, one city, one neighborhood. But that's what we need to be doing. That would have been amazing if I would have seen something like that, but it's not. As a matter of fact, those neighborhood clinics are kind of hidden. It's a little shameful. This is not a good thing. But how do we elevate their care too? Well, they're not going to go to Rush. They're just not going to go. They're not going to go to Northwestern. So how do we elevate that care? So that's really the challenge. I'd love to noodle on ideas, but that would have been great to have when we were younger, and certainly even with my mother-in-law, because she would not go to Rush. She stayed with her médico de cabecera, PCP. That's where she trusted, and that's where she was going to stay. So just challenge all of you to make this world a different place for all of us, all of my community in Pilsen, Mexican Americans in Chicago, but also all of those in yours. And thank you very much.
Thank you so much, Dr. Creo. That was truly amazing. Next, it's my wonderful, wonderful pleasure to introduce Dr. Rachel Whitmer. Dr. Whitmer is Professor of Public Health Sciences and Neurology, Chief Division of Epidemiology at the University of California, Davis School of Medicine. She leads the Population Brain Health Laboratory at UC Davis and is Associate Director of the UC Davis Alzheimer's Disease Research Center. Her research uses epidemiological methods to reduce inequities in brain aging through the study of dementia incidence, cognitive aging, brain pathology in diverse racial and ethnic groups, those with diabetes, and the oldest old. Dr. Whitmer will be talking to us about equity-focused interventions in the research engagement in underserved populations. Dr. Whitmer.
Okay, thank you so much for that introduction. Thank you so much, Dr. Kind, for putting this together. And thank you to NAC for organizing this meeting. It's really great to be here, and I'm really happy we're having these conversations. My funding disclosures: I receive funding from the National Institute of Health, from the Alzheimer's Association, and from UC Davis Office of Research. So I just want to start the conversation today and start thinking about how do we broaden our scope to include everyone who is in underserved populations, and that is a very wide definition of what that means. How do we engage people from underserved populations? Start thinking about what could equity-focused interventions look like, and what are the challenges and resources needed. So I hope today that you come away with thinking about these four things, but even if you think about one of them, that is great. I do think our network has the potential to be a leader, actually, in uncovering new risk and resilience factors in underserved populations. We do have people that are captured in our networks, but we also have a lot of people that are currently not captured. Inequities in brain health occur over a lifetime. We've been hearing about this today from Dr. Kind about having a life course approach, and these differences start at birth or even before. The challenges are not trivial. So let's talk today about inequality versus inequity, and I think this picture does a really good demonstration of what equity looks like. So when we're thinking about disparities in ADRD, we're thinking about the unequal distribution of health and illness due to unfair economic arrangements, poor social policies, and bad politics. It's not caused by differences in genetics or differences in health and illness. So health equity is the absence of systemic disparities in health. And this is something to be thinking about, how we can be promoting this in our work. So when we're thinking about the NIH Health Disparities Priority Populations, Dr. Kind referenced the wonderful article by Dr. Hill. And this covers a number of groups. And I've just highlighted a few groups that I think we might need to think about better ways about including them in our work across the ADRC network. So this is an example. This was published in 2016, looking at incident dementia over 13 years using Kaiser electronic medical records in 274,000 members. And we see here a incidence rate for Asian Americans. To our knowledge, prior to this publication, there had been no data published on the epidemiology of dementia in Asian Americans. There had been, wonderful work from the Haas study and the Kame study, but no one had looked comprehensively at Asian Americans as a group. And of course, there's great heterogeneity within that group. But this is just an example if you think about when NAPA went into place, and this was several years later. We still didn't have basic information on a huge part of our population on even the rate of dementia. So we're thinking about taking a framework approach, and sorry, this is actually, this side's larger, sorry. We want to think about biological and behavioral and sociocultural, but importantly, if you look along the bottom there, think about ways that you can interact to impact individual health, organizational health, community health, and ultimately population health. So this advantage and disadvantage happens over the life course, and these things interact, and risk factors can affect critical windows for different populations at different time points in the lifespan. So we know that underserved populations have a higher exposure to risk factors for brain health over a lifetime. This is just looking at low birth weight being associated with elevated dementia risk. It's known for a while that low birth rate is also associated with type 2 diabetes and hypertension. Place of birth is highly linked with risk of dementia. This is looking at Kaiser members and who was born in a high stroke mortality state, strongly associated with risk of dementia, even though everyone in this study was living in Northern California by midlife. This is looking at cardiovascular risk factors by birth region, another study being done in Northern California, the study of healthy aging in African Americans. And this analysis was led by Dr. Kristen George, who is faculty at UC Davis. And you can see here that those born inside versus outside of the stroke belt have a difference in their risk factors, even though they are living in Northern California. And finally, just to reiterate the point that there are differences occurring over the lifetime, these are results from our Life After 90 study where everyone is ages 90 plus, but in midlife, there are large differences in cardiovascular risk factors by self-reported racial ethnic group. And remember, these are people who lived to age 90 and agreed to participate in a study. And yet you can see a very large differences in percentages that are overweight or obese, hyperlipidemia, and hypertension. And this is at an average age of 44. So how can the ADRC network, in moving forward the science on life course contributions in underserved populations? Well, most studies get a snapshot. You ask a survey, and you collect information, and you have one moment to think about risk and protective factors. But as has been so beautifully illustrated by the ADI and the neighborhood study led by Dr. Kind, is that you can leverage residential address, and you can link to many different data sources. And if you ask people where they lived and where they went to school at different time points over their lifespan, you have a beautiful opportunity then to link to multiple other data sources and ask very unique questions. And this is just one example. We heard about the neighborhood study, but you can find out about air pollution, toxic chemicals, weather patterns, crime data, segregation, redlining, green space, food density. This is just the tip of the iceberg. So very important to understand where people live, not just currently, but over their lifetime. And this is, again, already being done in the neighborhood study. And I think the ADRC network can think about other opportunities to link and ask other questions about exposures across the life course. So coming back and thinking about priority populations, well, there's many challenges. And I'm not going to say the word obstacles or barriers because that sounds like it can't happen. These are challenges that we need to work on. Cultivating trust with communities to engage research participation. We just heard from Dr. Maria Carrillo, some communities don't have trust and don't want to go to the medical system. History, we need to acknowledge our history of abuse in research and have that conversation. There is a good reason why communities don't have trust. Time. It's hard to give time. We all have a lack of time. We've been talking about that today. But if you're working 3 jobs and taking care of 2 sick people, your time is even more precious. So time is not the same commodity across people. Money is not the same, and we had a great conversation about that today in the morning. So we need to start thinking about appropriate compensation. $50, $100, $250, it does not mean the same if you're living below the poverty line. Transportation, so how do we have access? In a lot of studies I'm involved in, we provide access, but we also have to think about meeting people where they are and thinking about what it means to conduct home-based research visits and do as best as we can to have resources to provide transportation when we can't do research in the home setting. So the ADRCs are based at academic medical centers. It's the ivory tower. And so of course, we have an overrepresentation of urban dwelling, highly educated people. That's just what happens. And so we need to step back and think about satellites. Do we need to think about going further out? How can we leverage underserved rural populations and settings and think about engaging them in research? What's the return on investment? This is a wonderful participant from my 90+ study. Why did you decide to donate your brain to research? She said she wanted to help longevity. We need to work on conveying to our communities that it's beneficial for them, it's beneficial for their children, it's beneficial for their grandchildren. If there's not an obvious return on investment, people will continue to be loath to give their time and volunteer their time to us. So we need to think about the IRB. And I put this here because the IRB is very concerned about coercion. But we need to have a really honest conversation about conveying to communities that have been underrepresented in research what the benefits of research are. We recently had a situation where my colleague was part of a podcast and being asked about the benefits of participating in research. And my colleague mentioned how this particular study includes research medical exams and that is a benefit of being in this study, is you will have a research medical exam. And the IRB accused my colleague of coercion. And we really need to have an honest conversation if we want to recruit people, and particularly people who may not have health insurance. We need to be able to talk about what's involved in the research and what does it mean to have a clinical research exam. And that is a benefit. And we need to have an honest conversation at a national level about engaging with these populations and having a new, fresh look at the definition of coercion. So where to next? So there's a whole science behind inclusion. There is a whole scientific field about how to engage and include people. There's a science about how to retain people. So we need to increase inclusion, but it's not enough. We have to contextualize our research so it means things to these communities, demonstrate return, engage appropriate compensation, access, and finally, we need lots of resources to do this. So again, I think we have the potential to be a leader. We need to think about what the term underserved means. These things occur over a lifetime. The challenges are not trivial. And I want to thank you very much for your time.
All right, thank you very much, Dr. Whitmer. Next, I'd like to introduce Dr. Laura Baker. Dr. Baker is Professor of Internal Medicine, Neurology, and Public Health Sciences at Wake Forest University School of Medicine, Associate Director of the Wake Forest ADRC, and co-lead of the center's OR-Core and REC component. She currently serves as the chair of the OR-Core Steering Committee. Please welcome Dr. Baker.
Hi, everybody. Do you need to stand up and stretch? You okay? All right. We like to shake it up a little bit, so I am not going to show slides. I just want to talk. I just want to have a casual conversation about kind of taking the conversation here and making an application to one example of an intervention that might be rolled out into the community, and then talk about what is our responsibility as an ADRC to make sure it gets from concept through translation so that it's implemented in the community. All right, so I'm going to talk to you from lessons learned from two of, I'm a lifestyle interventionist. I've been doing this for years. I care very much about meeting people where they are and finding ways to build their resilience, their physiologic resilience in efforts to restore health to brain. So my experiences, our lessons learned that we're going to just talk about here are based on our EXERT study. It's a large national trial of exercise, low and high intensity exercise in people with mild cognitive impairment. This study, we've had some preliminary reports at AIC and some media coverage, and it's not published yet, but this was 296 individuals with MCI. They exercised in the community at YMCAs under the supervision of a trainer. They were randomized, they completed 12 months. It was a randomized controlled trial, and our findings were that any amount, low or high intensity, any amount of regular supervised exercise stalled cognitive expected declines over a 12-month period. So we saw no decline in these MCI adults. We expected decline. We saw none for either exercise. So there's some caveats there that I'm going to talk about a little bit later here. And also my experiences come from US Pointer. It's a large lifestyle trial funded by the Alzheimer's Association, but we have learned so much from this study about how to meet people where they are. And we have learned about what is going to be our responsibility to push this kind of trial, if the results are positive, into the community for general consumption. So for Pointer, we are almost at 1,800 people enrolled. We have a target of 2,000, right? We've got people who have exited the study, so we've been in the field for 2 years, and our retention is 95%. So, and I think what I'm most excited about is our representation of communities of color is 30%. So we feel like we've learned a lot. We have a lot to say. We have a lot of work to do, but I think we have some messages that we would like to push forward based on these findings. So here's what we've learned about the must-haves for something like an exercise, a non-pharmacologic intervention. If you want it to succeed, you have to have the following. It has to be evidence-based. Don't try to push something out there that does not have evidence to stand behind its efficacy. You have to have buy-in from the community. Why should I bother? We have to be able to answer that. We have to be able to convince participants, or they have to convince themselves that it's important to do this. If we can't do this, we shouldn't bother. It has to be accessible to everyone. People have enough barriers. If you have mild cognitive impairment, you have barriers. If you're underserved for whatever reason, you have additional barriers, layer upon layer of barriers. There cannot be any financial barrier for this kind of an intervention. We're talking about randomized controlled trials still. We haven't talked about translation yet. It has to be tailorable to meet specific needs. One size does not fit all. And if you're going to design a study and everyone has to do the same, it will fail. You have to have some observable return for the participant. The participant has to feel different. It doesn't have to be physically, but it could be emotionally, spiritually, it could be anything, but there has to be an immediate return. Otherwise, it may get started, but it won't be sustained. It has to be translatable. If the study results are positive, there has to be a mechanism to push it out into the community. Otherwise, why are we doing this work? If it can't be translated, which involves community partners, why bother? It has to involve support. It has to involve support, and it has to involve support. These people, and I'm not talking about people with mild cognitive impairment, I'm talking about human beings, particularly those who have additional challenges in their life, cannot do something like exercise on a regular basis. Remember, excerpts findings were based on regular exercise. So regular is the operative word. If you exercise once, I'm sorry, you're probably not going to get benefits. If it's once a month, I'm sorry, you're not going to get benefits. So what are we going to do to help people be regular? Support, support, support. This is what we've learned. And we've learned that without that support, the study will fail. So if any of these must-haves are missing, I suggest you abort the trial. It's going to be a lot of money. NIA is not going to be happy. All right, so now let's say we have positive results in the trial. Oh, that's great, right? Positive results. Now what? What's our responsibility? And that's the question. That's where I am right now and our team with Excerpt. We got positive results. What's our next step? We're going to drop it? We're going to let somebody else we're just going to hope someone picks up the baton? We have a responsibility. So the question is, how do we intentionally move forward, move positive trial results forward to ensure proper implementation and long-term sustainability? That sounds, like, oh yeah, sure, we need to do that. But the investigators who conducted a positive trial need to be involved. They know what's involved to move that forward. You can't just pass the baton to someone else to get to start all over again. This is a lesson learned still. How do we make sure that we roll out these interventions to help address health equity issues? There are specific issues that you've learned as a trialist while doing the trial, if you've been successful engaging underserved populations, that you need to be at the table to help move that forward. You can't drop the baton. If the researchers don't move the trial forward, and I'm not saying you have to do it yourself, but if you don't decide, take responsibility to move forward, who's going to do it? And on what timeline? Our research moves incredibly slow. We work in isolation, we complete a task, and we say, okay, I'm done. Somebody else needs to take it from here. Unfortunately, no one else likely has the same passion that you do, that initiated your vision to begin with. You have to keep on. My lessons learned is don't drop the ball. So in translation to improved healthcare, it's going to depend on the following. Robust community partnerships. If you think you can move something into the community without a partner in that community, you're fooling yourself. It will fail. We need our community partners to roll these out into the community for widespread dissemination. We need that passion of investigators and the community partners to see it through. That's the commitment. If everyone had if you saw Gina Green-Harris' passion earlier today, if everyone had that passion about outreach and connecting with communities, we would be in a very different place now. We have to have passion. It's not all about intellect. Passion has to be part of the formula. We have to have stable financial support for these new programs. If it's unstable, we all know, and the new report makes a point of Building trust takes time. One lapse, one mistake can destroy a program. If we don't have sustainable funding, how can you trust, as a community member, how can you trust it's going to be there next month? If I don't know if it's going to be there next month, why should I go? If the community partner can't trust that there's going to be funding coming, why should that community partner invest passion in the project? So it's got to be sustainable financial. We've got to have adequate resources to support, to provide all my essential must-haves. And I'll repeat the support, support, support. If there's no resources to support the support, it will fail. And finally, we have to, this new program that's going to deliver this intervention, it's got to have an immediate return for the participant and the family. Bring more in. The family doesn't live in isolation. The participant doesn't live in isolation. The participant lives with a family. The more resources you provide for the family, the more buy-in you're going to have, the greater the sustainability. So how does the ADRCs fit into this picture? What is our responsibility? So I feel strongly that it is, when we start a project, we need to finish the project. If our jobs are to identify interventions that truly prevent disease, decline, we can't start it and then drop it. We have to take some responsibility for moving it all the way through from test to community consumption. And it doesn't mean that we have to do these trials, but we have to be intentional on passing the baton. Who is going to take it from here? So in Excerpt, I either need to be responsible for gathering a new team to make sure it's deployed, or I need to do it myself, or I need to engage community partners who can do that. And if I don't take that responsibility, I have failed as a scientist. Even though I got positive results, I've still failed because it can't be used until it's taken to the next level. And I just think the ADRCs, we have a responsibility, maybe this is the new era, we have a responsibility to somehow see it through, to make sure whatever you've worked on is disseminated. It's in full operation in some way or another. Yeah, and so it's just more, how can we commit as ADRCs to the full spectrum of the basic science, the early clinical trials, translational science to population science, and being part of the whole progress, not just elements that leaves the trial, the research process in fragmented forms. And so, as a ADRC, our responsibility is also to speak up loudly and often. Advocacy, advocacy, advocacy. It's our responsibility to make sure the science moves forward in whatever way is needed to make sure the people benefit. We're not doing our science for us. We're doing it for our communities. And so ultimately, whatever we do, we have to know that there's going to be an immediate, direct translation to the community. So that's all I've got to say. That's just my lessons learned, and I hope I've got my own work to do. I have to walk the walk myself, but I hope lessons learned will translate to new avenues for ADRCs to participate in the whole spectrum of research through to community consumption. Thank you.
Thank you so much, Dr. Baker. And next, we have Dr. Patricia Jones, who will offer the NIA perspective. Dr. Jones leads NIA's efforts in stimulating health disparities research related to aging and is director of the Office of Special Populations. She advances the science in eliminating health disparities, facilitating addressing health disparities through basic clinical, translational, and behavioral and social science research. Supports developing initiatives that strengthen NIA's research and training opportunities in these areas. So thank you and welcome Dr. Jones, who will be joining us virtually for the NIA perspective.
Thank you so much, Dr. Kind. I am so excited to join this conversation, and I'm going to take a cue from Dr. Baker and shake things up a bit. Rather than reference slides as I would traditionally do, I really want to take these precious moments to just engage in a discussion, a conversation that has been underway for quite some time, but highlight a few points going forward, as this is a very, very pivotal moment across NIH and within the field of aging in particular. And I don't want to be remiss in missing an opportunity to highlight where we can take advantage of these resources and the energy going on right now. To that end, I want to just take a moment back and step back and highlight the bottom line up front, if you will. And in thinking about the points that I heard Dr. Carrillo raise and Dr. Whitmer remark on, it reminds me of a few really essential takeaways. First and foremost in my thinking, as I look across the work that's underway in Alzheimer's specifically and aging, I want to encourage you, because each of you are absolute dynamite rock stars in your own right, and have the privilege and the pleasure of collaborating with really passionate, talented groups of individuals in the communities that you're supporting and working with. And I just want to serve as an opportunity to leverage your energy and imbue the core principles of engagement, as well as core principles of implementation science. We have several literature articles, manuscripts highlighting in the literature evidence-based interventions and strategies. We have documents that have been reporting what are some of those core principles of community engagement. You have tools, you have evidence-tested materials. We have plenty of resources and energy, human capital. What's missing is an opportunity to leverage that perspective of community involvement at a higher level beyond participation. And if we're thinking about participation, we should also be thinking about leadership, and leadership in our protocols, leadership in our teams, leadership that is consistent and congruent with the communities we hope to engage as a strategy for increasing participation and engagement. So with that in mind, many of you are familiar, and certainly we've seen reference the priority populations that are highlighted in the NIA Health Disparities Research Framework. And I just want to offer a perspective that beyond the framework being a tool that can spur thoughts around measuring intervention targets at different scales, different areas, I want to encourage you to consider the tool as an opportunity to revisit the team composition. And in terms of team composition, I'm really referring to perspective, expertise, background, in terms of who's leading our components and our activities, and how we can harness and harmonize the skill and expertise at every level. There's also a very rich opportunity to find meaningful, impactful research and measures that are highlighting the things that are working well so that others can replicate with confidence these activities. And so Dr. Baker graciously shared things that she and her team know work well. And as we continue to do the same and spread the word, we can have consistency and congruence across all of our sites that are engaging in this type of work, both NIA funded and funded by industry and other entities, and leverage the activities. We hope that we can benefit from the research being done irrespective of the funding source, and really catalyze on these lessons learned. I also want to share perspective in that as we are thinking about how we can leverage the lessons learned, that we lean in and really motivate each other, support each other in leveraging our personal and professional sense of agency. As I mentioned, everyone in this space is very much a thought leader, respected and recognized as policy influencers, design experts, community engaged research experts. And I just want to encourage you to leverage your professional and personal sense of agency and authority as you have the opportunity to have conversations with different entities supporting and partnering, collaborating the research in this Alzheimer's space, so that again, we have the benefit of harnessing what we know works and applying these approaches consistently in as many different settings and forms as possible. I do want to give acknowledgement. I think most are aware of broad scale agency-wide initiatives that have been underway for the past couple of years across NIH. Specifically, I'm referring to the Unite initiative, which is specifically focused on bringing forward racial equity within the agency and the biomedical extramural research workforce more broadly. But I hope also many of you are also aware, tandem to Unite, there are a number of efforts to impact and influence diversity, equity, inclusion, and accessibility. I think, of course, everyone funded by NIH is aware that we've had an inclusion policy for many years. It's the law. Cost is not an excuse or a reason not to better engage underrepresented communities, women or children or people across the life course. But we fully acknowledge and recognize that far more has yet to be done beyond having a law. And so I, again, come back and hearken to the fact that this is a very important pivotal moment. We have two major initiatives that are truly making this conversation a place that we can affect change. And I encourage you to leverage your sense of agency as you have the opportunity to not only publish and lead projects, but to influence in many different settings and forums, other thought leaders in this space. And I'll just end with one comment. Others in their remarks were commenting on the importance of recognizing reimbursement and the role and contribution IRBs may play in either promoting or limiting activities. And I just want to echo that, again, recognizing the backdrop, the broader scale efforts that are underway with calling for better racial equity, calling for more diverse, equitable, inclusive, and accessible research environments and activities, that the time is right to affect the changes you know you want to see within your institutions, within your agencies, within your settings, and to engage all of your partners in ongoing regular conversations, including institutional review board administrators, including grants management, including research team assistance and administrative support at every tier, every level, to have, again, that same level of appreciation and awareness of where we have an opportunity to establish and instantiate the changes we know and have been documented for many years in the literature to be important. All of you are fully recognize, I'm sure, and agree with me that COVID was a flashlight that reminded us of the work that we've already done and the work we have yet to do and where we can do better. And so I just continue to applaud you for the contributions you're making in the Alzheimer's space, but I want to encourage you to leverage your sense of agency as you continue to affect important, meaningful, impactful changes at policy levels, at research levels, administrative levels, within and around the communities that you are established and associated with. And I will end there and just note that there are a number of resources. I'm happy to send them in the chat to share more broadly with those of you who are there in person. But these are resources that go beyond evidence-based recruitment retention materials and speak directly to equitable models and frameworks for reimbursing community advisory and participant patient advisory board members, and resources that go beyond thinking of them strictly as a means to an end in terms of how we recruit and retain participants, but rather how we re-envision them as equal partners who are co-creating our activities and leading our activities, and how we might engage them differently if we're looking at this from a long-term perspective. And I'll stop there.
Thank you so much, Dr. Jones. I am so inspired by all of our speakers. Our time for discussion is short, but for those who have questions, we're going to try to keep going for at least a few questions. I would like to invite our panelists up to the stage if they'd like. If they'd like to take the questions down there, we're near the end of the day, whatever you want to do is fine with me. But Dr. Jones will stay with us virtually, and why don't you go ahead and come on up to the mic. Yes, Hank?
Yeah, and I will also just say for the virtual folks, we'll be able to hear you in the room and see you if you turn your camera on. Just go ahead and put your name in the chat if you'd like us to call on you for a virtual audience members. Thank you.
Hi, Hank Paulson, University of Michigan. Thanks to all four of you for a nice way to kind of bring us out at the end of the day. I heard lessons learned said several times, and I say this in the last 2 days. I've personally learned a number of lessons, and I'm taking them back with me. What inspired me really here in these 4 talks was the discussion of the ADRC Network, which is a distributed group of experts, informed, increasingly able to reach diverse communities, underserved communities, and we will get better at that, to be a point of action. And I want to come to you, Dr. Baker. Your point about getting the word out into those communities once something is found that is useful, such as exercise. The network, when we get funded, there are metrics by which they measure how you get funded. Are you a team player? Do you work with other centers in doing large-scale research? But we don't talk about, are you a team player in actually working together in implementing the changes that can occur across the network when something is found. So I hope that as a network, we think that that is an important way that we determine whether a center is doing their job. I think it is a new time. I think centers are different now than they were 15 years ago. And I think it's an exciting time for that.
I agree with you, and I think that's a very powerful statement that you made, and I think that's a charge to action for the centers in the network.
Dr. Carlson.
Hi, I'm Cindy Carlson, University of Wisconsin Alzheimer's Disease Research Center. I really want to echo Hank's comments and just, again, all the things that we've learned collectively, all the voices of our participants, our patients, our colleagues are powerful in helping us to understand that if we're going to do this right, we need long-term investment, the sustainability, investment in communities. We need to reach rural colleagues or rural patients and people in diverse communities, and that each communities be very different. So, you know, thinking about the ADRC network, we obviously have big swaths of the country that we're missing for the ADRC network. And then just thinking, you know, as I've been involved with NAPA, are there other ways you envision, you know, the Alzheimer's Association, CMS, NIH, CDC, other healthcare systems, PCPs, would there be a precedent for us to somehow build a collaborative model, whether it be state-based, somehow to build up some infrastructure? Because that's going to be long. If it's going to be long-term, it's not going to be the 5-year grant cycle, which we've talked about. You know, you can't get that community engagement and then the grant's done, and by the time you recruit your first person after that trust's been built, the grant's done. So what are your thoughts, especially those of you who have the national roles, how we could partner to really make sure those swaths of the country are not, the rural areas are not missed because the ADRCs aren't there and other communities?
Well, that's a great point, Dr. Carlson. I think I have a couple of things that we have already started to do. They're actually not in my area because I'm the sort of medical and scientific area, but they are in an area where we are building partnerships with health systems. And so we have, I think, 300 relationships with health systems from small to large. And a couple of ADRCs are actually a part of those relationships, but only like maybe 2. So it would be great to be able to expand those conversations with Alzheimer's centers across the country, as you're saying, because that health system approach is really critical. What we have lacked to date that I think all of you could help us with are very specific evidence-based metrics that we can share, that then the health system, it entices the health system to want to work with us. And what's the evidence that it actually, unfortunately, is an economic benefit for them overall? Not only do people get healthier, but that means that they have less costs associated with it, right? Resource utilization. So we need a lot of that work. Maybe that's an opportunity that in which we can all work together. Now, that doesn't get to all communities, but it gets to more communities. And I know we've been talking with Wake, I know Suzanne is in the room, Dr. Kraft is in the room, around piloting a system that we might be able to do, because Atrium is a 6-state system. I'm trying to have conversations with Indiana, with Dr. Harris, about how we can test some of these things out within single states or systems, because that's very important. And then it rolls up to, you certainly could roll up to Napa as examples.
I think that's such a great question, and completely agree with Dr. Carrillo. And just to expand upon that point, right now with these policy changes going forward in equity and payment, that will be affecting presumably a huge number of health institutions across the country. Many of these institutions do not have community engagement in their DNA. They're trying to learn how to do this, some of them for the first time, or thinking differently about not just focusing on those blue areas on the map to build the orthopedic hospital to try to get as much, funding as possible in our capital fee-for-service based healthcare system. But suddenly they're being incentivized to go to places that had not been attractive before from a business model. The ADRC network has such expertise in this area. We have such expertise in this room. And wouldn't it be wonderful to be able to partner with those health systems, help them understand exactly how this should be done? How do you elevate the community voice? How do you make those connections in a way that is feasible and sustainable in a larger scale? And this, of course, is important for brain health, but it's important for all health. So I do think that we also have great expertise that ideally is communicated towards those other non-research sectors in order to hopefully leverage coverage, just as you're saying, Cindy, because I completely agree. I think there are huge areas that could benefit from the resources in the system.
And Cindy, I'm going to add one more. You asked a loaded question for all of us. I think the ADRCs are starting to add to their portfolio of types of trials to include pragmatic trials.
Yep.
And we do, pragmatic trials offer an opportunity to use mail and telephone. We may not have all the standard measurements that we want for the UDS and for NAC, but it maybe opens the door for new kinds of measurements to reach people that are far away from medical centers and test the accessibility of very simple interventions that could have more application for large numbers of people in a way that maybe more of our other pharmacologic interventions we aren't able to test in that way.
Yeah, I know they're working on the practice-based research networks and all those initiatives. And hopefully that the healthcare systems recognize the importance of clinical research too. That'll be adapted. But thank you all for your.
Thank you so much. Dr. Maslia?
It looks like
Yeah.
we have a question for Dr. Maslia, and then after him, we're going to take a question from the virtual audience.
Actually, I was going to ask along the same lines as Cindy. So then let me just follow on that. The way NCI has gone about it, as well as all of us, is by creating satellite community centers where a lot of the recruitment of diverse populations happens. And apparently it's a model that has worked well for them. I know that some of the Alzheimer's centers actually created or have created satellite centers. When I was at UCSD, Leon Toll created a center in El Centro, and he used to fly his airplane back and forward, and we used to go there back and forward. And I see Jim Brewer here. He might remember those days flying in the airplane with, well, it was not an airplane. I don't know. It was like a small biplane. But somehow, it eventually, it's so hard to maintain and sustain those satellite clinics that, or at least in San Diego, they end up letting go. But and I don't know what has happened in other Alzheimer's centers, but we have explored at NIA level that possibility. It's something that we have brought in internally, but not a lot of traction has happened. What do you guys think about that option? You have experience with that. Is that something that it might be worth for us exploring again?
Well, I don't have experience, so you're the experts. And so we have someone with experience that might answer. But what I do know is that in our communities, our local community health centers need a lot. They are impoverished, just to even be able to handle the patient load they have. So you can help so much so that you don't have to spend the money to stand up a new satellite. You have satellites ready. You just need to have the right people that look and talk and act like them to come in and say, how can we help you? What do you need? And develop those relationships. They're out there. There's a ton of them. And they need help.
Okay.
Yeah, I think just to echo that, when I became director of Wisconsin Alzheimer's Institute, we have 36 clinics throughout the state of Wisconsin that do memory care. And so I envisioned that we would just, buy out people's times, the primary care providers, and let them do the recruitment. But they don't have the time. You buy out 20% of their time. That's 20% fewer patients that can be seen in their community, because they're the primary care provider. So I think there's a lot of there's people out there, community centers, primary care providers, but it's trying to figure out how to get that value added to them, how we can invest in them. So it's hard.
Yeah, right. Don't come in and think that you're going to get paid, referrals next week or next year. But you will in 3 years, you will, because now they trust you. They might be able to say, well, how do we do a quicker memory exam? What do we do with our patients who have that? Once they trust you, because you've given them all kinds of stuff. I mean, and I know that I've seen some centers have great fairs for La Raza. They'll have them, and they'll have parties and all Mexican food, and they bring a mariachi, and you got to go to the downtown area and you got to go to the center. I'm like, why don't you give a community center some money to do a health fair that just gives blood pressure checks and diabetes checks, and go and do that type of thing instead of doing it at your ivory tower? So I think we need to think a little differently, and know that this is a long game. This is a long game, and we got to be invested in that long game.
Thank you.
All right, I think we have some questions online. Is someone from NAC able to field those?
Yes, I believe Dr. Jones and Dr. Brewer actually wanted to comment on this most recent question, and then after them, Dr. Ashford has a question.
I'll defer to Dr. Brewer. He had his hand raised patiently.
Oh, thank you so much. I was just going to, thanks, Eliezer, for mentioning that satellite approach that has been effective. We essentially did the experiment. It was under Leon, there was the satellite, and then the satellite went away, and we saw the community. And so we've reestablished a South Bay Latino Research Center satellite, and it is so key. The piece was, we also have 2 fellows, Spanish-speaking fellows, that we established in the South Bay, and we've started doing weekend memory screenings at their clinic, and it's really changing everything to be in the community. I mean, I think that's just such an important piece to note, that yes, it's really, really hard to establish in the community. I know Wisconsin also made a lot of successes with Milwaukee and others, and it's just a lot of hard work, but it's absolutely critical. So I just wanted to echo that. Thanks a lot.
And just to add to the point, among the opportunities I have to engage in conversations related to this topic include opportunities to engage community-based clinical settings. And I've been contacted by a number of hospital systems in the middle of the country and other places that are interested in becoming more involved in aging research, but they're not research entities all by themselves. And they're trying to figure out how they can become partners and collaborators going forward. And so I just, again, come back to a remark that I made earlier and encourage each of you to think a little beyond the things that may have been implemented thus far. And there may be opportunities to engage healthcare systems from the community perspective, but recognize that, of course, there are fiscal considerations that would need to be considered so that they don't serve as additional choke points and barriers for those entities to participate and collaborate. They won't have the same administrative savvy that many of the academic centers have. And so that will require a level of investment and partnership to help them set up contracts and other mechanisms, and of course, equitable reimbursement, but they are ready and poised and interested in collaborating around research questions and have access to the very communities that we are trying to better engage.
All right, thank you so much. I think we have time for one more. I think there's one more online comment. Is that right, Nac? Sorry.
Yes, so Dr. Ashford, he can ask his question, and that will be our final question.
Okay, sorry to end it this way. I'm Wes Ashford. It was a really excellent conference. Just some outstanding material was presented and extremely important. I did see quite a few old friends in the audience and around, and old acquaintances, but I'm really excited to see so many young new people that have gone into this. It's been a while since I've actually been very active in this field, but I heard a tremendous amount of discussion about the difficulties of trying to establish outreach mechanisms. And Dr. Masleo mentioned Leon Thal, who is nice that he went over to El Centro, but he crashed his plane into a mountain one night, and that was really unfortunate. The question is, what can we do? And I think the thing I heard that I felt was the most positive here of something that you could really do was Rhoda Owl's presentations about smartphones, and that smartphones are really used. And it seems to me that you can do really excellent assessments, not necessarily with paper and pencil. I think even better, you can use a smartphone or a remote computer. And I think I heard about some excellent presentations of testing that can be done with computers on memory remotely with smartphones very, very briefly, very inexpensively. And it would seem like that, out of all the things I've heard, would be the one way forward that would be practical. I just wanted to see if anybody had a comment on that. Thank you.
Practical, but I have concerns about bias in reaching underrepresented groups or marginalized groups. I think we just need to make sure. I know that there are some preliminary data suggesting that that is not going to be an issue, but there's still. I just still think that the door is not closed there. We've got some more work to do. There's a lot of confidentiality, trust issues that need to be resolved. And although some communities may be have been sampled, there are many other communities have not been sampled. And I just think we need to continue to listen and to what other communities are telling us before we push this out.
Thank you.
I think that I think that the cell phone, this is Maria, I think the cell phone is definitely something that needs to be explored. I think it is already being utilized in some cases. But for underrepresented populations who have an automatic distrust of research, right? My family won't do it. And I've asked my aunts and uncles that are still with us, because my father was one of 15, why would they participate in clinical trials? They're like, no way. Let somebody else be the guinea pig. I'll take it when it's ready. I mean, this is the attitude, and so there's no trust. I'm not going to give you more information than you absolutely need already because the government's watching me. So even my husband, who's an intelligent MBA from Kellogg, will not give his information. And whenever he has to even give an email address, you know whose he gives? Mine. So that he can avoid providing his email address. So, I mean, this is just a mentality. There is zero trust of any system. I'm not going to give you more than you absolutely need, even though he knows with his iPhone he's being watched and tracked. So, I mean, it's just a reality.
Yeah. I just want to echo, going back to a point that I raised around core principles of engagement. And as much as we're leveraging technology, we really need to be mindful about testing and learning what technology is acceptable and viewed as a trustworthy mechanism for different communities, and not make assumptions that because it works well with one group that everybody will want to use it or feel comfortable. And it really is not so much about education or background. It's really a bigger issue around trust, a much bigger issue. And I can think of a number of people with terminal degrees, 6 figures, who do not trust and will not do surveys, research using platforms and devices because they're concerned about who has access to information. So we just need to be mindful about how we move into communities and broach that topic and explore how we can better leverage those resources appropriately.
Well, I want to thank all of our speakers today for this session. It was a quick whirlwind session. We stayed a little bit longer. We could probably stay all night having this conversation. It's so good. Thank you, Dr. Carrillo. Thank you, Dr. Baker. Thank you, Dr. Jones. Dr. Whitmer had to rush to the airport, unfortunately, because of the traffic. But and thank you all for engaging and for staying a little bit later. And thank you for NAC as well for coordinating such a nice event. So thanks.
Thank you, Dr.
Oh, yes, thank you.